Dr. Timperley is a chief of cardiology at the Northampton General Hospital, and is also a very active member of Pace for Life. We have been with him. He has taught us. I've been with him in the Northampton. I've learned a lot of techniques from him, and he has also come to Nigeria to teach a lot of us so many techniques. We are really, really privileged to have him talk to us today on cardiac resynchronization therapy and the management of complications that may arise from any of such procedure. So we are grateful to have you, Dr. Jonathan Timperley, being with us today. It's a pleasure to have you, sir.
Thank you very much. It's an absolute pleasure. It's been a pleasure being in Nigeria and also having Dr. Edafe come over to the UK. So just a little bit, this presentation will include, I will give you a warning, some military aircraft. I spent 20 years in the Royal Air Force, and I cannot have a presentation without some military aircraft. So please excuse me when they do appear. It is a form of therapy for me, and I hope you enjoy.
Yes.
So what we're going to look at, and this is really just going a bit to the background of what is CRT, how does it work, and then we'll look through the technique of some of the techniques of doing it, and then one of the complications that can occur. We've got a few slides on dissection, because I know when we were out in Nigeria, we had a dissection over in Lagos, and so just a couple of video clips showing what we can do, and then a discussion on how dissection occurs and what we can do to try and avoid it. So we'll go back to some of the pathophysiology and some of the original studies, because I think it is important for us to realize where we've come from. We'll look at the brief. I'm not really going to go too much into the current indications because we know about that, but we'll more be looking at the technical aspects of implantation. And as I've mentioned, you've got to have some past and present aircraft of the Royal Air Force in all presentations. Now, heart failure is a big problem. This is UK data, 11,500 annual deaths from heart failure, and up to 40% of those will die within the first year of diagnosis. And when we look at where the money is spent on these people, 60% is spent on in-hospital care. So we've got a therapy in terms of CRT that has been shown to, as well as improving mortality, as well as reducing symptoms, it also reduces hospitalization. And when you've got limited resources, such as the NHS does in the same way as, and obviously differently in Nigeria, but we have limits on our resources, then if we can do something that is going to reduce hospital admissions, that is a good thing. And when we look at what happens with these people with heart failure, in the general heart failure population, we see that about 15% of people will have either inter or intraventricular conduction delays. But when we go to the moderate to severe group, so those generally with the NYHA class 2 to 4, then the presence of that usually intraventricular conduction delay is about 30%. So we know is as people move from mild to significant heart failure, there is a worsening of their conduction. And this study was, the Venogram study was a study into an agent that was trialed for looking at prevention of people requiring transplantation. What it did show that Venogram actually killed people, so they stopped using it. But what they did have was a lot of data on people with heart failure, and they were then able to then look at what were the risk factors for death in these people with significant heart failure. And unsurprisingly, they found out age was one, worsening renal function, worsening left ventricular ejection fraction, an increasing heart rate. And they also found a very beautiful correlation between the QRS duration and mortality. And what they found within 1 year, with those with a narrow QRS, they were finding up to a 10% mortality. But in those with the broadest QRSs, over 220 milliseconds, then they were getting up to a 40% mortality. So as your QRS gets broader, your risk of death goes up. But in terms of symptoms, it's not quite as straightforward. So when we look at people who have NYHA class 2 with heart failure, and we're talking about people with the same ejection fraction, so if you just consider anyone with ejection fraction of 30%, then what we find is that 2/3 of those people, which is the pale blue block, will die from sudden cardiac death. but your mode of death changes as you go worsening symptomatology and get into MIHA class 4, when actually only 1/3 of those people will die a sudden cardiac death. The majority of those people in MIHA class 4, actually progressive pump failure is the cause for their death. So having people with relatively modest symptoms, they are the people who tend, unfortunately, to drop down dead from ventricular arrhythmias. And that's important, obviously, for the ICD selection, as well as those for a CRT. And that, obviously, in New York Heart Association class 4 is a contraindication to putting an ICD. And that makes sense, because you're not doing just with an ICD component, you're not doing anything to improve LV function and to improve pump function. All you're trying to do is stop sudden cardiac death, but the majority don't die from that. So, and what we're interested in, and hopefully this is that playing okay, Julius? Nod if it is. Yep, good. We're looking at people who've got hearts like this, and here's a beautiful example. You could look at that lateral wall on this 4-chamber view on its own and say, there's not bad left ventricular function just on the lateral wall. But when you take into account what's happening in the intraventricular septum, this has got a calculated ejection fraction of 4%, because all of that blood is being sloshed from left to right. When you look at the mitral valve, it's really not really opening up because of high left ventricular end diastolic pressures. So that's what we've got, and that's what we want to be treating. And so the elements of cardiac desynchrony, we have AV desynchrony, we have interventricular desynchrony, but really the area we're looking at with CRT is the intraventricular desynchrony. And there are lots of different ways of measuring this, but actually, and ultimately, the ECG still remains the primary determinant of whether we should consider CRT therapy. We can use, M-mode parameters, we can use speckle tracking, we can use TDI, but actually, they're useful, especially as a research tool, but actually the ECG remains a prime tool for assessing people for CRT. Now, what are the deleterious effects of desynchrony on cardiac function? Well, as we saw in that first example, and here's another one, when you have a desynchronous left ventricle, you get a lot of sloshing of blood, which increases, and with the associated increase in end systolic volume, because you haven't ejected the blood, then you get increased wall stress. You can get post-systolic thickening, which has no impact on the ejection fraction because the aortic valve is closed. You get mechanoenergetic inefficiency. And you can also get mitral valve dysfunction such that you can end up with pre-systolic mitral regurgitation. So you've actually worsened your ejection fraction before you've even started. So all of these components really impair the left ventricular function. And we do worry about the AV delay, but actually the majority of people who've got an AV delay that runs between 50 and 130 milliseconds actually are probably in a relatively optimal position. As you get really long AV delays, then yes, we can impair left ventricular filling, but the AV delay, yes, we can optimize it, but actually what we really need is the left ventricular pacing component. And that is a beautiful picture of a Canberra PR9 from RAF Marham 39 Squadron. I looked after these guys back in the 90s. And at altitude, that aircraft is better than the U-2. Sorry, AJ. And actually, the Americans then bought this and put bigger wings on to go even higher than the U-2. And NASA still use that to date. And it's outdated, or its flights actually have gone longer than the U-2. Good Canberra. Anyway. So infranodal conduction delay, the most common that we look at is left bundle branch block. We have got a nice indication in the UK for with right bundle branch block for CRT. But what we really want to see, we want to see a juicy left bundle branch block. And we'll get associated with that intraventricular desynchrony, as we've mentioned. Now, we know that right ventricular pacing is bad, and the top one is looking at the David trial, and this was looking at in ICDs using either a DDDR or a VVI pacing. And what we found, surprising at the time, but now in retrospect it makes sense, was that with increased RV pacing associated with DDDR pacing, there was an increased episodes of death, first hospitalization for heart failure, and death of any cause. So RV pacing is bad. And we also know from most study where as you increase the RV pacing percentage between 0 and 40%, at which point it then becomes irrelevant, there's an increased risk of atrial fibrillation and heart failure. So if you've got someone you're pacing at 40%, you might as well pace 100% because it isn't going to make any further change in their risk of atrial fibrillation or heart failure. But if you go down from 40 to 30%, that significantly reduces their risk of AF and heart failure. So left ventricular pacing, this is what we're interested in. We want to get into that coronary sinus and then hopefully get somewhere into the left posterior wall to pace and improve function. And the acute effects of left ventricular and biventricular pacing are actually similar. So when we look at the delta change in aortic pulse pressure or the max left ventricular dP by dt, which is another measure of cardiac contractility, both of them similarly improved across any AV delay, the aortic pulse pressure or the max LV dP by dt, and that, as I say, left ventricular only or biventricular pacing, but RV pacing is significantly worse. What about the LVRV offset? Well, most of the original studies use simultaneous stimulation. There are groups of people we're going to find who prefer left ventricular pre-excitation and others who prefer right ventricular. And there isn't an overall standard setting for everyone. So this is a suck it and see element, really.
Hey, Dr. Timperley, question for you there. So there's been like a lot of the research I've read is that a narrow QRS is associated with better outcomes, and kind of what you've said here. So when you have LV first activation and you kind of have that isoelectric portion of that QRS where it doesn't look like you're actually activating something, but you probably are, you would count the QRS from the initial pulse, correct?
Absolutely. Yeah, it's not from the, because you, exactly, you said, you end up in the situation where you're going, oh, I haven't actually started my QRS. You have started your QRS. You may not see what you've that. And that's what, when we look at these patients, we're actually measuring contractility instantaneously, especially when you're looking at dP by dt. We've shown that in multiple, both animal and human studies in the initial part, that there are groups of people within 3 beats, you will have an improvement, and it's not automatically associated with a change in the QRS. So we will end up with a group of people where we can improve their dP by dt, and it's not the same as reducing the QRS. Having said that, there is a degree of correlation, but it's not perfect. And so you end up having to take it individually. Now, we can't invasively measure dP by dt. Doing it by echo is not great. And the ECG is a good initial assessment. Does that make sense, AJ?
Yeah, that's perfect. Thank you. Yeah, I've always kind of wondered that because I think people will cheat and say, oh, you know, our QRS starts here. Like, yeah, well, the first pace is actually the induction.
Absolutely.
Thank you for that. Because
you've got, you know that you've got, you have paced the left leg, you know you've paced the heart. The fact that you cannot see that initial phase is irrelevant. Very good question, AJ.
JT,
yeah.
Really quickly. So on your ECG, so I'm assuming the best model for biventricular pacing on the 12-lead ECG, V1 and lead, V1 and lead 1. Normally you want, obviously, you want negative in lead 1, and you want like a right bundle, narrow complex right bundle in V1. Is that right?
Well, I mean, what you get in V1 is a composite, isn't it, really?
Yeah.
So you've got your left bundle, which comes from LV only pace, from RV only pacing. You get a dominant R with V1. You end up with a composite. I don't care what the shape is, because the shape
that was my question.
Where you are pacing. Yeah, I'm not interested in the shape. So I am interested in the QRS duration, but not the shape. So if you've got a dominant R wave in V1, that is fine. What we're interested in is what the QRS duration across the board is.
Brilliant. That was my question. Yeah. Excellent.
Right. One thing that does really matter, and this has been perfectly demonstrated, is site matters. So this is looking at pulse pressure and again dP by dt, and there is a sweet spot perfectly in the middle. You want to be in the mid lateral position, and that's why often when I pace in the CRT and the technician said, okay, do you want to use 3 and 4? Well, actually, we know from all of the studies originally that mid-lateral position is the important bit. So I will say, okay, yeah, we can use any of them, but if it's all things are equal, I want the one which is in that mid-lateral position. And we'll look at the examples on the venograms in a bit. So what are the effects of CRT, both chronically and acutely? Well, if we look at the dP by dt, we can see that within almost instantaneously, there can be this improvement in this on the left-hand slide, going from 500 to 800. And then there's still a further persistent improvement up until 3 months, and then it stabilizes. And if you turn off the pacing, there will be an immediate reduction in that dP by dt. Not quite down to baseline, but there will be. On the flip side, if you look at their end diastolic volumes, then there is a gradual reduction. You turn off the pacing and there is no change, and there's a gradual remodeling back to the original baseline. So we've got 2 elements. You've got one element, which is acute hemodynamics, and another element, which is chronic reverse remodeling. And that's why you get some people as super responders in the initial phase, and you get another group of people who don't respond really for a few months until their volumes have reduced. And there are plenty of studies looking at all different parameters that I'm not going to go through all of those. Now, this is an important one, and this is that the CRT improves, but actually also improves your oxygen uptake. Now, if you compare the same group of people who either have use of dobutamine to improve their dP by dt or LV pacing, both of them improve the dP by dt by the same amount. The difference is dobutamine increases your oxygen requirement, whereas actually LV pacing reduces your oxygen requirement. And that could lead to some of the mortality benefit because you are reducing their oxygen requirement at an intracellular level. And so that can lead to a reduction in terms of ventricular arrhythmias. Mortality, we know that actually 2 of the biggest, the original trials, Companion, which looked at both CRTPs and CRTDs, looked at a composite endpoint of death and hospitalization as the primary endpoint, and then death as a secondary. And what we found was with the CRT that there was an improvement in terms of the primary endpoint. And when we look at the secondary of mortality, there was a trend with CRT, but didn't quite reach statistical significance. P was 0.06, but a CRTT definitely did reach statistically significant improvements. And when we look at the CARE-HF, which is randomized to 1-to-1 with medical and medical plus CRT, we saw a similar thing, the composite reduction to from 55 to 39%, but we did in this group see a benefit from 30 to 20% in terms of mortality, and that was over about a 4-year study. So CRT does reduce mortality, not massively. And when we look at the numbers needed to treat to save a life, then we are in the order with a CRT and Companion of 25 or a CRTD of 14 patients. And when we compare that to primary prevention ICD studies, such as MADAT1, it's significantly higher. But when we're looking at all these other studies, so for example, CIBUS-2 and MERIT-HF, which are looking at beta blockers in heart failure, they're actually, the numbers needed to treat are less than those very important trials, and we think it's very important we get a beta blocker on. Well, great, but actually getting that CRT is probably more important. That is one of the most beautiful aircraft in the world. That's a Victor KC-1 tanker. It's a beautiful aircraft, and the noise is phenomenal. Very low when you see it. It's got a very short undercarriage. It's a beast.
Looks like the Nimrod, doesn't it?
It's not, no. When you put that next to Nimrod, nah. This is hunkered down. Come on, if you think you're hard enough type stuff. So this is what we want to do. We want to convert this left-hand slide. Apologies, stolen from Medtronic, but hey-oh. And then we want to get that desynchronous left ventricle into this to improve the dP by dt and in the long term to reduce volumes. I'm not going to mention that one actually because it's not valid anymore. Narrow QRS, the studies show it doesn't work. Don't do it. And that is a beautiful photo. I took this. This is the Princess Mary's Hospital in Acute in Cyprus. This was during the Second Gulf War. This was a guy's final trip in an F3 Tornado, and we did some close formation. I can nearly see the camera make on his camera over there. So this is what we really want to see. This is give me a CRT. We've got a broad left bundle, nearly 200 milliseconds. We've got a first degree heart block, PR is about 240 milliseconds. It says, give me a left ventricular lead. So what do we do? And these are from my time in Oxford. So we're going to make our pocket right down to the prepectoral fascia, get under that prepectoral fascia, because that gives you the tightest pocket afterwards. And then we're going to do, as we saw as with Dr. Edafe, use an extrathoracic subclavian puncture. It is, you could say it's an axillary vein. It's actually technically, depending where you are on the rib space, it's probably a subclavian, but you're in the vein before the subclavius muscle. Catheter wise, you know, there's multiple different ones. I tend to prefer, as my first shot, this extended hook shape. This is actually a St. Jude one, but I generally use the Boston one. The deflectable catheter from Medtronic is quite useful, but it's expensive for what it is. You don't need it. And generally, we can get away with an extended hook. I use that 99% of cases. Sometimes more of a simple hook. So if you get rid of that, the black bit there, just that sort of shape will do for small hearts. So here we have, we got someone, we got the RV lead in, we're in LEO looking, and we get a venogram, and we can see we've got in with our balloon, and we've got this nice posterolateral branch. There's more of an anterior one, and we've got a middle vein down here as well. And here in REO, we can actually now see there's quite a tortuosity on here going into this branch. And I think if we go to the end, we will see now this middle vein actually now comes round underneath and actually marries up with the tributaries over here into the anterior and that lateral vein. And what we did, we actually tried to get in here, and we were able to get a inner 90 catheter to get into here. We could get down here. Unfortunately, Mr. Phrenic nerve lived all the way along there, and we were unable to paste that. So we actually ended up going down underneath to the bottom, and actually we got a good separation. And if we can see here in the LEO view, we want to be in that mid position. It's a little bit on the low side, but that's not bad. And we got a lot of separation over here. So we wanted to be in the mid third, which we're just about there. And we want to be in that lateral position over here. So it's not a bad position considering what we had to play with. Unfortunately, CS dissections occur. So here we have one. So we've now got this large dissection. It's compressing the coronary sinus up here, and this was caused by a JR4 catheter. Using a JR4, I love JR4 catheter, it's my favorite weapon, but it is a rigid tip. You have to be careful with it. When you're advancing it, you generally want to have your 3/5 guide wire or a smaller guide wire on it. But if you do get a dissection, generally you can just sit and wait it out, sit on your hands, listen to music, and then things can settle. But in this case, it didn't, and we really wanted to see what was going on. It's compressing this. We didn't really just wanted to abandon things there. So in this case, what we did, we then wired up into the true lumen of the main coronary sinus. We then put a balloon up and dragged it back all the way across to reoppose that dissection flap. And already we can see we've got a little bit of blood in there. And we were able then to actually see we've now got some flow into this vessel. And then we did try again, I think we could get in there. Ultimately, we found the phrenic nerve. So even though we wanted to be in there, we ended up having to go through the middle vein to the bottom. But in terms of the dissection, you can use a balloon and drag it back as long as you're 100% confident you are in the main coronary sinus and not in the dissection flap. If you do that with a balloon, that's game over for the day. You're going to have to leave it and then come back a different day because that isn't going to reoppose in a short period. A small dissection flap with a balloon, it will work. What we want to do is to see this converted into this. And this is one of the, this is one of our ones from JR. We've got the two bits. You can see an improvement in synchrony, and what you can really see is a reduction in the end diastolic volume. And this is a super responder who ended up with ejection fraction of 54%. That's what we want. Unfortunately, we don't get that all the time. But when you do, it reminds you that this is a good therapy. And when things are going wrong, it's difficult to get in the coronary sinus. It's this that keeps you going and stops you going to dermatology, because this is what makes the difference. What about learning curve? Well, there is. You know, when you're looking at your times, we're looking really about the 3-hour mark as an average for your first 5. But you gradually get down under the 3-hour mark as an average in your next 11. And that keeps on going down, and getting times of 90 minutes for a CRT is entirely feasible. But you just need to work on it. And it does take time to get those times in the lab down. In terms of device complications, unsuccessful is quoted at up to 10%. I think nowadays it's less than that. This is in a slightly old Insync 3 Attain. And the issue generally is the left ventricle leaf. Coronary sinus can either be an issue in terms of you just can't get in because of valves. And if that does happen, then putting I find if you've got a valve in the middle of that coronary sinus, the best thing is to try and get a wire across it, and then taking either an inner 90 or a JR4, and then peeling around to open that valve to get your JR4 or your inner 90 across, and then get your main CS across. Infection, 30-day mortality. That 30-day mortality actually is similar to those with severe heart failure. So the 30-day mortality from CRT is no different from the baseline of having severe heart failure. If you go back to the QRS of 200 milliseconds, I've got a 40% 1-year mortality. And the procedural death, I mean, it is uncommon nowadays. Kind of problems, well, the big ones, phrenic nerve stimulation, it's still a pain. We do have some options with doing transseptal punctures, etc. A 30% non-responder rate, it's still there, unfortunately. But the big ones are making sure we identified our patients, because we're not treating all of them. And we know that it's a big benefit to do that. So hopefully we're saying that CRP, it improves lots of things acutely, and non-responder is still a problem, but the ECG still remains our basic tool. And hopefully that's giving you some examples of things that can go wrong, including with me. Any questions?
So I was going to ask a quick question, JT.
Yeah.
So the non-responders that you were referring to, do you think such group of patients could benefit from left bundle pacing, or is there a case to be made for?
You're asking the wrong person there. You know, I'm not a big fan. I'm still not convinced of that yet.
Right.
It's getting there. The one thing I do know, I think LV only pacing is and we've demonstrated acutely that LV only pacing in some people significantly improves DPBIT compared to BIV pacing. So I personally would go for have a trial of LV only pacing if you've got that option, and you haven't got any concerns of LV only pacing in terms of underlying complete heart block, for example, and stuff like that. So that would be my preferred option. Optimizing, you know, the echo, the multi-center trials looking at echo optimization showed it don't work. So you can do it, and I'm sure on an individual case basis there are people who do it, but as a group it doesn't work.
Thank you. AJ?
Yeah, no, that's a really good presentation. I appreciate it. So I want to get your opinion. You kind of talked about CS access, but would you mind just talking about your process in general? You referenced using an extended hook, using a JR4, but yeah, just so people can understand your toolkit. And
let me just go. I have a very small toolkit. And as I say, I'm just going backwards to go to the pictures, but generally an extended hook shape, a large hook with 2 curves, is because the majority of the coronary sinus will not be linearly related to going across, they will be pointing up. And so having something which does have a nose that points up, I believe is beneficial. It also means the other way of getting into it is if you end up with a catheter in the right ventricle and then torque it so it back counterclockwise, so it's pointing to the septum. When you pop out of the tricuspid valve, it may pop into the coronary sinus, but you need a double curve for that to occur. If you've only got a single curve, such as one of these ones, then it's essentially straight. It won't do that for you. And the JR4, I use that. I put I literally do a minute with the extended hook on its own and a wire and a bit of puff contrast. If it doesn't go in immediately, then I'm going straight for the JR4. I take the CS catheter, I will stick that in the middle of the right atrium and then use the JR4 to hunt around for the coronary sinus, and sometimes it's not where you think it's going to be. You can sit there hunting in a region going, I'm sure it's going to be up here, I'm sure it's right here, and you end up with a coronary sinus right on the floor of the right atrium, and it happens. So if you're banging along and you're sure you look in the right place, you probably aren't, because if you were in the right place, you'd have found it. So it's at that point, just reevaluate and go, okay, I'm going to look somewhere else where it may not be expected, either really high or really low, and they do happen.
Fantastic. And then for wires, you referenced wire. Do you have a wire preference?
Yep.
If you had,
well, I'm old-fashioned, so I stick with a 3.5 steel guide wire to get into the CS. It's not going to do any damage as long as you've got a curve on it. And you know, if you've got something you can't get across a valve, I may convert to a Terumo to go across that. I prefer using a Terumo rather than an angioplasty guide wire, just because of the extra stability it's got. But 99% of the time, you can still do it with a 3.5 guide wire, because it's about getting once you've got the wire across, it's getting that nose of an angled catheter to peel that valve. That sort of, if you imagine a half moon, it's peeling that valve open such that you can then get your catheter in.
Right. Brilliant. We've got a question here, JT.
Brilliant.
From the chat group. It says,
Yeah.
Sir, please, what are the issues with right ventricular pacing, and if the 30-day mortality for severe heart failure is the same as those with CRT? Any need for CRT, or is it a few percentage of patients?
Yeah, I mean, the CRT mortality is the mortality in patients who had a CRT, whether they got it successfully or not, was actually similar to the baseline underlying risk of death. So if you have someone who's got a QRS restoration of 220 milliseconds, you're looking at a 40% mortality in 12 months.
Okay.
Worst case scenario. So if you then take that, divide that by 12, that gives you a 1 month mortality of up to 3%. And these studies in CRT had to report the deaths within 30 days of the implants. So was that the cause of death? Probably not, but they have to report it as such. And we have to accept that that death occurred within 30 days of a CRT. Would that death have occurred anyway? Probably would.
Okay, I think you've answered follow up to that. Yeah.
Yeah, the RV pacing, I think I was asking about that as well. I think you kind of touched on it, but if you want to kind of read.
Yeah, so RV apical pacing is bad. You know, if we're looking at His bundle pacing, etc., you can try His bundle pacing. You can perforate and tamponade the Medtronic catheter for doing it. They got up to a 10% tamponade rate when they're using their 4 French catheter for that. So you've just got to be careful with new technologies and making sure, even though something may not be perfect, something you're trying to see if better may not actually give you what you want. You know, our death rate from RV pacing is nigh on 0, but chronic RV apical pacing may lead to, in a small group of people, to worsening heart failure and atrial fibrillation. So yeah, we should be avoiding RV pacing, but at the moment we don't have a true perfect technology that will give us a much better procedure without new complications, because we don't tamponade in RV pacing really. If you do it gently, it doesn't happen. But if you're going to go His pacing, then you can do.
I think that's an important distinction too, is that RV pacing is better than no pacing if the patient is dependent on a device, but it still can lead to exacerbating heart failure. So if that's your only solution, then use the solution you have. But if you do have, you know, LV delivery option.
Absolutely. And I think that comes into making a decision. And we're not really touched on this because it wasn't in this talk, but, you know, looking at LV prophylactic pacing for people with a degree of impairment who then need 100% pacing. So if you have got someone who's got an ejection fraction of 40%, they're going to complete heart block and they need RV pacing, it's going to make things worse given the LV lead. But that's a different talk.
Yeah. Quick scenario that I've obviously come across in clinic. So there was a patient who had a profound AV block, wasn't pacing. It was a pacing, but the AV conduction was about 320 milliseconds. It was V-sense. So they've been like that for a while, and then they started getting a little bit symptomatic with breathlessness and things. So so I was arguing that basically this patient needs RV pacing, essentially, just to narrow the AV delay, A pace, V pacing.
I mean, there are groups of people where that AV as we showed on that chart, you know, you've got to get a really long AV delay to truly get into the area where you're causing true hemodynamic compromise. So that's not to say that some people aren't sensitive, and that you know, that just goes down to having to look at those on a case-by-case basis, really. And they may feel better. You know, there are people who you can change an AV delay, turn around and go, "What have you done?" Because I feel better. And you're going, "I've only changed it by 40 milliseconds," and then suddenly you're feeling better. And you can tell me that. I mean, that's, you know, there are people like that.
So in that scenario, if the patient has got LV dysfunction, or would you consider pacing their RV if they've only got good LV function? Or would you
No,
have
not if you've got, no, I wouldn't do that. So if you've got someone who's got ejection fraction of 50%, I'm not putting an LV lead in.
Okay. No, I meant for the RV pacing, you know, this is RV, we're talking about RV apical pacing, and for somebody who so if they've got like a poor LV function, would you consider shortening the AV delay and just pacing their RV, whereas previously they were not RV pacing? Would you
well, I'd much rather
to help their symptoms?
I'd much rather put the LV lead in.
Okay.
You know, if you've got somebody who's got severely impaired LV function with RV pacing, put the LV lead in, because we know we can improve their LV function. You can take someone who's got an ejection fraction of 40%, drops down to 20% with RV pacing, and then you can improve that up to 40%, and never even into an ICD category. So especially in the elderly, that's what you want to be doing. You want to be avoiding, you know, I don't want to stick an ICD lead as an extra lead into an 85-year-old unnecessarily. So yeah, I've got no problems with sticking an LV lead into anyone, any age group, but as long as you've got a good indication, and that one would sound like it.
Yeah, okay, brilliant.
I think this is a question that we've discussed before, JT, is that, you know, is it a long AV delay with no pacing or a short AV delay with some pacing? And I think you've kind of said avoid RV pacing if possible, if I remember correct, because there's kind of a debate on that.
Yeah, I mean, and that's because that percentage makes a difference if it's under 40%. So, you know, if you go from 40 to 30%, your absolute reduction of AF and hospitalization is around 2 or 3% per annum. So, you know, it's a significant event, but you then end up having to play off patient symptomatology. You know, it's mortality at AF and heart failure risk versus symptoms. And they may feel so much better with that shortened AV delay, which does increase their pacing. And then you just have to take it on the chin and go, yeah, it's not what I would like in terms of the RV pacing percentage, but they feel so much better that that's worth it. And that's where you just have to weigh one against the other.
Right. There's a question here from the same person in the chat group. So it says, Sir, what could suggest a patient may be a poor responder to ask CRT? And I can't see.
Well, there are MRI studies showing that the scar doesn't pace. So, you know, a lot of these people in the UK, we will have an MRI scan. And if you see that lateral wall is completely toasted with complete transmural infarct, it may suggest that it's not going to work. Having said that, I don't think I would. Unless it was completely gone, I'd still have a go. You know, if you made that decision, just because it is infarcted, I'd still give it a go, because there'll be a small group where actually the MRI doesn't give us exact data, and there may be enough that we can conduct, and I would do it.
Brilliant.
So I think as long as they're within indication for it, right? Or if they're going to be 100% pacing, there's an argument.
Absolutely.
I would say.
As long as there's a standard either prophylactic or a standard secondary, you know, because of the ECG that we do it, then yes, I'd give the MRI would not stop me doing it.
Yeah, I think one thing you touched on, anodal stem. So just for the rest of the group, it's important to know that like anodal stem can occur, but you can work around it by bumping up pulse width to voltage. By pulse width, you can lower your voltage and have a decent margin of capture threshold to destem threshold. Sometimes you'll be in trouble where you're going to get diaphragmatic stem. No matter what, you're going to activate that nerve, and the patient will have like a hiccuping-like symptom repeatedly, which is obviously not something that is good for their quality of life. But just to keep that in mind is that there's always options. There's always programming. You don't have to necessarily, you know, find a different lead placement. And correct me if I'm wrong, Dr. Timperley, on that. but sometimes you can just work around it. If say the SIM threshold 5, the capture threshold is 2 at 1.5, it's viable.
And this is where it's really good to record the 12-lead ECG during those swings where it changes from anodal to without. So you can end up with 4 different ECGs. But if you don't know that from the baseline, then it's difficult to be sure just from the ECG. So if that does happen, it's important to get that recorded, that 12 lead, and get it stuck in the patient's notes. So in the future, you can look at it, and when thresholds do change, anodal stimulation threshold changes, and you know where you are.
Awesome. Dr. Edafe, have you got any questions?
Yeah, very few questions. Thank you very much, Dr. Timperley, for the excellent and very great lecture. I want to ask a few questions. One is, if you have a patient, 60 years old, and he had ejection fraction 20%, dilated ventricles, and the QRS complex are narrow, but also have a complete heart block. Will you agree that we should go for a CRT for such a case?
Yes, I would. And that's because now you could make a case because you are going to pace 100% of the time. Now, if they've got a left bundle branch block, there is a difference in terms of what happens. So if you have a left bundle branch block and then you pace the left ventricle, RV pacing is still worse than native LV left bundle branch block. But the there's a significant difference between that delta with an underlying narrow complex when you will significantly make things worse. So in that case, absolutely, I put an LV lead in.
Good. Then my second question is on the mid-lateral position. Yeah, is the best position to slit in the LV lead, but in case you do the CS venogram, you could not get a very good mid-lateral position. Which other position do you recommend? That is one. The two, if you are entering into
I'll come back to your question. I can't keep 2 questions in my head. So
yes,
so to answer that one, I'm going to show you the delta. So going into the apex, 30%, but you can still get in the apex 18%. So you're getting a significant improvement, but just not as good. So you shouldn't write off the apex. The base is a different kettle of fish. You've got 2 issues when you start looking at more basal segments. One is looking at the improvement of dP by dt. The second issue is stability, and you need to get enough lead in there to keep it stable. So I would tend to go towards the apex because there is still an improvement in dP by dt rather than going to a basal position. And whether that's and the same is true when you're going more anteriorly or more inferiorly. You still get an improvement in the mid position, whether it's a bit too anterior or a bit too inferior, but it's just not as good in that sweet spot.
Okay. Then the second question is when you are navigating into the middle cardiac vein, what are some of the techniques that you use? Because I know you demonstrated some of those techniques when you were with us in Nigeria a few weeks back.
Yeah.
Did you get the question, sir?
Making a venogram, you need to be making.
I think we've lost you, JT.
Yes, we lost him. Maybe because he's driving.
Yeah, that's right. Yeah.
Yeah. So that will affect the network. Then while we are waiting for him, AJ and Julius, there is a way you do the setting of, you can set the timing to shorten the interval and also narrow the QRS complex while programming the device. What are those tips all about? I know you did it for the cobalt. AJ also did it for some of the Abbott implant devices we did.
Jules, I can take the first part if you want.
Yeah, sure, go for it.
Yeah, so you're looking at a number of when you're trying to optimize LV pacing. So one of the things you're looking at is your LVRV offset timing, which is what Dr. Timperley briefly spoke on, is saying, are we doing simultaneous pacing or are we doing some LV activation early? You rarely will have RV first pacing. You may have it in some patients with like a right bundle branch block, but typically that's not a strong indication for a CRT to begin with, so you're unlikely to even have that. So your LVRV offset is one of the things you're looking to optimize. You're looking to optimize your site of pacing as well, so your site of activation. There's opportunities to multi-point pace, which if you look at those leads, the new modern quadrupolar leads, you have 4 electrodes to choose from, and you could choose to pace from usually the site of latest activation. So typically the site of later electrical activation, and then 30 millimeter spacing away from that has been shown to have better outcomes than a shorter spacing, so a better anatomical physical space between those electrodes. So typically you'll find the site that is activated later in the electrical chain, which means there's more electrical desynchrony. Pace from there, and then you'll have your, if you do it, multi-point pacing at a 30 millimeter or greater spacing to activate there. So our LVRV offset, site of latest activation, site of multi-point pacing, so separation, and then finally your AV delay. So a lot of these devices have the modern devices have automated AV delay algorithms like SyncAV or Edafe in Medtronic, where it will measure the intrinsic induction system and then subtract a delta from that and then pace accordingly. So you get what's the idea is like a triple fusion, or at least a dual fusion of the intrinsic coming across, your LV pace and your RV pace, all activating as much tissue as possible. And that can result in the narrowest QRS. There isn't a study, I believe, that has direct data on that, but Trucco et al., I can find the study data for you, has come up with basically narrow QRS or fusion optimized intervals are associated with better outcomes. So a algorithm focused on narrowing a QRS would have a better outcome overall, is the idea, through the trans property. Sorry, Jules, go on.
Yes,
I kind of ran over you.
Sorry, no, I think you've answered everything. I mean, the only difference between Medtronic and your one, Medtronic have got the algorithm called adaptive by V, LV, and it gives an option for good AV. Anyone who's got good AV conduction, you can certainly go with adaptive by V, LV. The LV works. I mean, there's been studies that have shown by Medtronic that shows that LV pacing only is good for the patient on 2 counts. The first one, it gives battery longevity because you only pacing the LV. And the other one, obviously, that there's good outcome, CRT responder from that. So I know other people argue against that, like they prefer the by V pacing only. And there's an algorithm that uses that only it uses to pace the LV, that it works out like 70% of the AV conduction, the normal physiologic AV conduction. So it paces the LV 70% of that timing interval. So it pre-paces the LV, so like calculating that the right ventricular bundle will electrify the right bundle will electrify the right ventricle roughly about the same time. So it paces around about 70% of the timing of the LV, of the AV delay, and it paces LV only, uses so it is by V, but one half is natural conduction, the other one obviously is LV pacing. So the algorithm to think about, but hang on, is so I've got JT on the phone, who's going to so he heard everything we said, but I'm just going to hold the phone so he can answer the latter part of your question.
Beautiful. Go ahead.
There you go, JT.
Okay, hopefully you can hear me. So it was like Dr. Edafe's question about the middle cardiac vein. So in order to get into that, firstly is getting the venogram done. So making sure you do a long enough venogram so you can see the tributaries from the anterior vein, feeding the middle vein, so you can see where it is, and you can see the os of the middle vein. You need to know that for getting in. Secondly, the easiest technique for getting in there is to take an inner 90 catheter, because 99% of the time, the middle vein is pointing straight down the screen, and have it poking out of your main coronary sinus catheter, and then pull, not by much, by about half an inch, so at least it can turn inferiorly, drag the main CS down, and then rotate the inner catheter 180 degrees, so it's pointing downwards, drag back until the inner 90 engages the os. You usually see it as a drop, and once you've done that, wire with a 3/5 guide wire or a Terumo if you prefer, the inner catheter, and then advance that inner catheter, and usually by rotating it another 180 degrees, you'll get round that first corner, and usually you can get that inner catheter as far as you want into the middle vein. What you really want to be doing is not being in the middle vein, you want to be getting into the tributaries feeding into the lateral vein, so you can work your way around posterolaterally in the heart.
Great. Very important, yes. Well cleared. Thank you very much, Dr. Timperley.
You're welcome.
Great.
So the end of what I was talking about, the algorithm, is that if the patient's is quite narrow, AV conduction is quite small, then what you could do is actually put it to non-adaptive. Dr. Edafe, put it to for Medtronic,
yes,
non-adaptive, and actually decide on what the AV interval is, make it shorter. That way you won't get maybe competition, and if they're getting a lot of V-sense coming through. When you look at the rate histogram and you get a lot of V-sense, like if you look at the far end, the higher rates, it might be worth basically putting it to non-adaptive and shortening the AV delay more, so that there's, it paces as much as possible when you get interruptions of the CRT. So that's another one to bear in mind. And that people with normal AV conduction, you can certainly by V, adaptive by V, LV, certainly is good. But everything AJ said, like pretty much he covered the whole lot. So it's exactly the same, slightly different algorithms. It's got multi-point pacing as well. It's all relevant and that. So
very good. Okay, nice. Maybe ask any other questions.
Sorry,
AJ.
I was saying, Julius AVs, do you prefer 140, 110?
Yeah,
typically for fixed AV delay for non-adaptive.
Spot on. Yeah, spot on. 140. Yeah, it seems to be the nominal settings for a lot of people. Yeah.
Yeah. So 140 milliseconds for your paced AV delay, 110 for your sensed AV delay. Something to keep in mind with the group is that when you're sensing, you're seeing the activation late, right? Because if your lead is sitting in the RV and it is sensing the activity in the RV, it's already worked its way through the chain to get to that lead. So anytime you're having a sensed AV delay, or anytime you're trying to fuse with an intrinsic conduction, you have to remember that you're not seeing the instantaneous, electrification of the heart. You're seeing a delayed wherever you're sensing from. So you're always going to have a shorter sensed AV delay. You're always going to subtract the delta from your dynamic AV algorithm to pace LV a little earlier, because you're trying to fuse with something that's already occurring.
Excellent. Yeah, fantastic. Sometimes we do 120 paced and then 90 sensed. But obviously, like you said, normally between 140 and 110 milliseconds for sense. You can change it, between that. A lot of other hospitals have got different protocols that they go by, and that. But that's right. That's right, AJ. Spot on. Yeah.
Thank you. Appreciate it.
So, any more questions? Anyone? Dr. Oladimeji, because I know you're learning your CRT. I'm sure you've got questions.
No, not really. It has been fantastic lectures. All true. I just appreciate the great teachings. So with these teachings, what we now do at our site is to now go back and read and reread. So anytime I usually post it to AJ, and then he tries to demystify the questions.
Excellent,
So,
excellent.
so
Brilliant, brilliant.
so.
Anyone else? If not, I'll just sign JT. Well, that was really fantastic. That was excellent. Really enjoy that. So that was really good. Thank you for that. So we'll let you go for you to focus on the rest of your driving. And we'll see you at some point this week at work. Excellent. Nassim, go on.
Yeah, very great teaching.
Yeah.
Thank you.
Thank you.
Right.
So if we can get to Dr. Mrs. Apana.
Oh, yeah.
Yes, because that's LBP area pacing has been waiting for weeks to months now. So if we can get to her, if she agreed to take her lecture next week, then we can take it next week. What do you think, AJ Angelus?
I mean, yeah. Sorry, AJ, you go ahead. Go ahead.
So if all feels. Oh, I was just saying. I think Zane is always waiting in the wings to do one as well. Yeah. So we could always have two discussions because left bundle is very new to the region. Obviously, it's new to the world. To be honest, it's only a couple of years old. So I think having as many different, perspectives on this is important. So if he's available, that would be amazing, and then we can do a follow-up one with Dr. Zane Sharif as well.
Beautiful.
Fantastic. Brilliant. Brilliant. And I know Dr. Sharman, speaking to him just last week, he was really keen on it because he's interested in bringing it to Northampton. So I did ask him to come on. So he will come on next week if it is coming on.
Good.
Good.
Good. Yeah. Thank you very much.